Hello and welcome to today's NBMT Link webcast, How to Take Ownership of Your Survival Plan Post-Allogeneic Transplant. At this time, all participants are in listen-only mode. If anyone should require operator assistance, please press star 0. There'll be a question and answer session following the formal presentation. You may ask a question at any time by typing it into the Ask a Question feature on your screen. As a reminder, this conference is being recorded. It's now my pleasure to turn the call over to Jennifer Gillette, NBMT Link Staff Social Worker. Please go ahead, Jennifer.
Thank you, Kevin, and thank you always for helping us with these webinars. Welcome, everyone. So glad you can attend today. We have a wonderful lineup of presenters here today to help you as you are owning your survivorship plan post-allogeneic transplant. Just a brief little outline and an introduction to us at the link before we get started. First of all, today we will hear from Dr. Minoo Battiwalla. He is the Director of Outcomes Research at Sarah Cannon Transplant and Cell Therapy Network. And then you will hear from Beth Ades, an MDS survivor, a wife, a mom, and more. And then we will have our question and answer period. As you might note on your screen, there is an area to ask questions, and we will be answering those once the presentation part is complete today. Or at least we will answer as many as we can, depending on how many there are. For anyone who is new to NBMT Link, the National Bone Marrow Transplant Link is dedicated to helping individuals and their families from diagnosis through survivorship. We work with hospitals, cancer centers, and other organizations to reinforce and complement medical care by providing resources, support, and education. We link you to experts across the country in all topics related to transplant and to others who have made it through the journey before you. To get in touch with us, there is our phone number and some emails you can reach out to us as well. Some of those resources we have are our Lunch and Learn programs monthly. We have 15 seasons of podcasts with over 30,000 downloads. We do multiple webinars. One, which you are on here today on survivorship. We do a cGVHD or graft versus host disease webinar. Our next one will be in December. And we have blogs for those who have been through a transplant process and really just all things related to transplant, including disease-specific information, survivorship issues, coping and symptom management. We have our Survivors Thrive Book Club and other programs to connect to community and fellow members. Peer support mentor program is for both patients and caregivers looking to talk to someone who's been through the experience and is doing well. We have our Second Birthdays Recognition program, as well as award-winning books and materials, emotional support, and a licensed social worker for referrals and resources. A special thanks to our webinar event sponsors, the Leukemia and Lymphoma Society, Johnson & Johnson, and our esteemed Link partners for their continued support for all we do. Just as a reminder, today's presentation is meant to inform and support. It is not intended to replace your individualized medical advice. Now, introduction to our wonderful speakers here today. Again, Dr. Minoo Battiwalla. He joined Sarah Cannon in 2018 as the Director of Outcomes Research. In his role, he designs and leads retrospective outcomes research across the Sarah Cannon Transplant and Cellular Therapy Network, with a special emphasis on blood and marrow stem cell transplantation and cellular therapy. Dr. Battiwalla received his medical degree from the Medical College in Calcutta, India in 1994. After completing an internal medicine residency at Stony Brook University Hospital in New York, he finished a fellowship in hematology oncology, BMT, at the National Institute of Health in Bethesda, Maryland. He also earned a Master of Health Science degree in clinical research in 2003 from Duke University School of Medicine. Prior to joining Sarah Cannon, Dr. Battiwalla served as the medical director of the Blood and Marrow Stem Cell Transplant Program at the National Heart, Lung, and Blood Institute in Bethesda, Maryland, from 2010 to 2018, and he chaired the NIH BMT Consortium. Previous to this, he was an assistant professor and associate scientific director at Roswell Park Cancer Institute in Buffalo, New York, from 2003 to 2009. Dr. Battiwalla has spearheaded efforts in the field of stem cell transplant survivorship and has co-chaired the NIH Late Effects After BMT Consensus Initiative, as well as the Center for International Blood and Marrow Transplantation Late Effects Working Committee. Dr. Battiwalla is actively certified by the American Board of Internal Medicine with further certification in hematology. And then we have the lovely Beth Ades. She is a survivor. She is from rural Iowa, married with one daughter, and is also a cat mom. She was diagnosed with MDS in 2021 and received her stem cell transplant in 2022 at Mayo Clinic in Minnesota. Beth is passionate about giving back, helping, educating donors and their families, and shares infectious joy for life. She currently sits on our board at NBMT Link and helps us make our organization the best it can be. And without further ado, I would like to welcome Dr. Battiwalla. Thank you for being with us today.
Good morning, everyone. I would like to appreciate the opportunity to speak to all of you and this kind invitation from our sponsors at NBMT Link. My name is Minoo Battiwalla, and I'll be talking to you about how you can actually take control and own your survivorship after undergoing an allogeneic transplant. As you have heard, I have been performing stem cell transplantation for more than 25 years, and I consider that survivors are very special in this battle against the sort of diseases that many of you have faced. I want to acknowledge your journey through this very extreme treatment. So, increasing success in the field of allogeneic stem cell transplants has led to an ever-growing increase in the numbers of transplanted survivors. And with such success comes a focus on long-term survivor health. We believe that by the year 2030, we'll have at least 500,000 transplant survivors in the United States, with about 40% having undergone an allogeneic stem cell transplant and 60% being adults in the age group 18 to 59. And as you can see on the graphic on the right, the growth is expected to be exponential. But it's important to understand that as time goes out after transplants, typically if you have had a transplant for acute leukemia, your risk of relapse diminishes to almost nothing if you haven't relapsed by 3 years. However, beyond that time, survivorship is assured from the standpoint of the malignancy, but there could be growing health problems. Also, I want you to realize that given the huge numbers of survivors, there's a risk that survivors can simply overwhelm the resources transplant centers have to care for them, which is why I would like to bring up this concept about taking ownership of your post-survivorship care. And we can only wish that all our transplant survivors look as healthy, fit, and toned as the participants on a television show. But as you know, the reality is somewhat different. And you could select the transplants, but there is often a cost. I like to use the term battle scarred. Here are some statistics. 40% of childhood cancer survivors will have severe illnesses or die from such illnesses. After a transplant, even if you recover from the treatment, there could be later effects, and there's a psychological burden, the so-called sword of Damocles, looming over one's head, constantly reminding us of additional problems yet to come. Now, for an allogeneic transplant survivor, more than 80% will have at least one late effect at 5 years post-transplant. And the sad reality is that these are not just quality of life issues. 5-year life expectancy for a transplant survivor is actually lower than that of the general population. So this is a serious issue, and we need to tackle it with a lot of foresight. Alexander Solzhenitsyn is quoted as having said that it's not the sea that drowns you, it is the puddle. In other words, you don't want to succumb to correctable minor issues that are created in the wake of the transplants. So, congratulations, you are a survivor. Now what should you expect? The message for today is it's important to take ownership over your health. Why? The benefit is that you avoid drowning in a puddle. In other words, avoid possibly reversible issues. And the big benefit is you could also greatly improve your quality of life. What do you need to do? You need to stay alert for long-term or late effects. These are health problems which can occur later and or stay for a long time after transplants. When to expect these complications? The time frames for each complication are actually very different. And this is why we talk about transplants and we use time frames when we discuss time out from transplant, because complications have their time frames, and if you enter a certain time frame, it's very unlikely that you are liable to have complications which could have occurred a long time ago. So how do you manage this? You do this by taking control over complex multidisciplinary care delivery. All right. Next slide. There we go. So these sort of survivorship issues can affect all domains of health, not just the physical. It's important to recognize that there could be sexual side effects, emotional side effects, psychosocial issues, and almost universally financial issues. And many symptoms and conditions can actually be ascribed to the transplant process itself. So, if you're undergoing something strange, one of the questions you must always ask your physicians, your care providers, is, could this be related to my transplant itself? And if so, does this have some sort of different treatment? When we consider the causes of these long-term and late effects, they fall into several overlapping groups. The first obvious reason is there could be complications of the underlying disease. But the conditioning chemotherapy and the cumulative chemotherapy that patients undergo has a major role. There could be underlying genetic preconditions or pre-transplant comorbidities. And finally, there could be immune dysregulation. Immune dysregulation refers to the paradoxical setting where you have both hyperinflammation with chronic graft-versus-host disease, and at the same time, you have weaknesses in the immune system which give rise to infection. So one way to consider these risks and individualize this is to ask your doctors the question, did you receive radiation? Do you have chronic cGVHD? How bad is it? What organs are affected? And are you male or female? Because survivorship health is influenced by all these factors. Now, we talked about the time frame of complications, and in this graphic, which shows the time frame in years after a transplant, understand that transplant side effects can occur many, many years, even decades after the transplant. In the initial first year, we worry about, actually in the first 100 days, we worry about acute forms of graft versus host disease. But beyond 100 days typically, and up to 2, 3, 4 years after transplant, chronic graft versus host disease and its sequelae can be a problem. Infections can be a problem typically very early, but also later. And then the risk of relapse from underlying malignancy is usually over by 3 to 5 years. However, this is just the beginning of several other transplants. For example, late cardiovascular issues and late new malignancies can happen and can actually be prevented. So we will talk about some of this, but I just want the message to go out that events can occur many years, even decades after the initial transplant. So when we think of key late effects, I like to divide them into 2 groups. First is those on the left, which actually influence your survival. And the second group on the right, which influence your quality of life. And late infections, second cancers, heart issues, and lung issues can greatly impact your very survival. So it's very important to be on top of them, and it's actually fairly easy to address them if you catch them early. Chronic graft versus host disease, which is this inflammatory storm induced by donor immune system attacking innocent body cells, is a driver for all these late effects. And the quality of life issues basically can affect almost any organ system and include endocrine problems, bone problems, sexual and fertility problems, iron overload issues, general health, including fatigue, cramps, sleep, chemobrain, as well as mental and emotional problems. These are distressingly common in all our transplant survivors. Thankfully, they are not necessarily fatal. So let's move on to the immune system. As I pointed out earlier, immune dysregulation is very common after transplant. And the graphic on the left demonstrates that even years after an allogeneic transplant, ranging up to 12 years, we can demonstrate that late infections occur and are fatal, potentially fatal. So the vast majority of these infections are bacterial infections, but you can also have fungal, viral, and multiple infections at the same time. So how do you manage this? Thankfully, most infections can either be prevented or treated. And many of you are already on treatment like antifungals, antivirals, anti-PCP drugs, and occasionally antibacterial drugs, particularly if you have significant chronic graft versus host disease. Penicillin prophylaxis is generally recommended. Now, vaccinations. Vaccinations after transplant represent the biggest bang for your buck. And when should you start? I recommend starting at 3 months after the transplant with COVID and influenza vaccines, because these are critical disorders, and even partial immunity that you can get by immunizing at 3 months can be a big deal. However, the routine revaccinations against all your baby illnesses should generally be deferred for at least 6 months after allogeneic transplant, and I generally insist that they are off all systemic immunosuppression. So this might mean that it might be 2, 3, 4, 5 years after transplant before you actually start getting the rest of your baby shots. Do not be in a hurry to get them, because if you're on active immunosuppression, the vaccines don't work. Now, second cancers are actually quite a challenge in patients who have received a prior allogeneic transplant. The new terminology in the field labels them as subsequent neoplasms. And there's a threefold higher risk. And this is an entirely different cancer from the original disease for which you might have been transplanted. And it is linked to the cumulative doses of chemotherapy and radiation. The more treatment you have received to control your original malignancy, the more likely you are to have subsequent neoplasm. Thankfully, it does not happen right away, but if you see the graphic on the left and you look at the incidence curve for the expected rate of cancers versus the incidence curve for what is seen in transplant survivors, it is quite staggering. So how do we manage this? Well, it's really dependent upon having a very comprehensive approach towards cancer screening. The skin is one of the commonest sites of cancer. And I will give you an example. I had a patient who used to expose himself routinely to the sun when he would drive as his truck with one arm outside the cab and the other arm inside. And this was while the patient was living in Buffalo, a place which is really not noted for its strong sun. 5-6 years after the transplant, I had to remove about 15 skin lesions, many of them cancerous, from the arm which was left outside the cab, and none on the arm which was left inside the cab, suggesting the huge influence of sun exposure. So a dermatologist skin exam annually is recommended for most patients, particularly if you have significant sun exposure. Sunscreen is important. Avoid peak sun, sunglasses, hat, and use sun protective clothing. This is such a simple thing to do, but you really have to avoid the sun. I encourage my patients to think of themselves as vampires. The sun will kill you. Thyroid problems possible. You need an annual physical examination. Oropharyngeal cancers mandated dental examination every 6 months to a year. Stop all tobacco and alcohol, including oral tobacco. Human papillomavirus vaccination is really important in stopping a large number of human papillomavirus-based cancers, because HPV-linked malignancy is seen in maybe 5% of the general population, but can influence 25% of the cancers seen after transplant. For the lungs, if you're ever a smoker or a vapor, that has to stop, and select patients may be eligible for low-dose CAT scan screening, particularly if you have been a smoker. Breast cancer guidelines exist, and women who have, particularly those who have had radiation, will require breast examination and screening even earlier than the general population. Cervical cancer is a gynecologic cancer, a very high risk of cervical dysplasia and precancerous issues caused typically by reactivation of the human papillomavirus. All women need regular gynecologic testing, including HPV testing, such as by a pap smear or a HPV DNA test, and HPV vaccination. Esophageal issues are possible, colorectal cancers are possible, and those follow guidelines for the general population. What can you do about heart problems? So what is the issue here? Transplant survivors are at a higher rate of cardiac events. So there is actually all the underlying problems that give rise to coronary artery disease and heart disease are actually accelerated in transplant survivors. And by risk factors, we mean risk factors such as hypertension, diabetes, cholesterol issues, obesity. All of these are overrepresented in transplant survivors. When you have all these risk factors acting in tandem, you could have a risk of premature events. On average, the first heart attack occurs 14 years earlier in transplant survivors. This risk is permanent and increases with time after transplant. Thankfully, all these risk factors are correctable. So once the dust settles after a transplant, I recommend starting screening in the first year, making sure you correct the correctable factors such as cholesterol and blood pressure. And then in select patients, you can do additional testing such as echocardiograms and cardiac CT scans. The lungs are the last major vulnerable organ. Nobody should be smoking or vaping after a transplant. Infections are common, and it's important, therefore, to get vaccinated and seek medical attention early. Often, lung inflammation will present with what we call infiltrates, that are shadows on X-rays or scans, and not all of them are infectious. Very often, they are inflammatory, and this is where you really need to call your transplant center the moment you have any problem with your lungs, because it might not be a simple pneumonia. Even though it is labeled as a pneumonia, it could be an inflammatory, non-infectious complications. These can occur early post-transplant or late post-transplant, and this is a very distressing issue. And if you ever have any problems with your lungs, please, please, please contact your transplant center. There are two forms of graft versus host disease of the lung. One is called cryptogenic organizing pneumonia, and the other one is called bronchiolitis obliterans. Recognizing and distinguishing them is very critical, and this is why lung function tests are very important to pick up early traces of lung graft versus host disease, and we recommend that you get lung function testing regularly, at least every 3 months if you have chronic graft versus host disease in any other organ, or 6 to 12 months otherwise, and usually this frequency can stop after 3 to 5 years. But in those 3 to 5 years, detecting lung inflammation early is very critical. Now we come to the more common but and more frequent issues, but less life-threatening. About a quarter of patients will have low thyroid levels, and that can be easily supplemented. Higher risk of diabetes and dyslipidemias can be corrected. Sex hormones are universally reduced because of ovarian and testicular failure. So this can result, of course, in low sex drive, which may not matter to some individuals, but more important can be fatigue, vaginal changes and pain. Erectile dysfunction is common, and so is infertility for the vast majority of transplant patients, particularly those who have received more intense chemotherapy or radiation in their conditioning. For ovarian failure, I strongly recommend hormone replacement therapy up to the natural age of menopause, which is early 50s. For patients with documented low testosterone, this has to be documented on the basis of a free testosterone level and not a total testosterone level. In my personal experience, all men who have this condition try testosterone supplementation, and it just does not seem to make any difference to their quality of life. Bone health is important. Again, there are two patterns. The first is osteoporosis or osteopenia, shown on the left, and the other pattern is avascular necrosis. Osteoporosis affects all the bones and results in weakness and the bones becoming progressively more spongy and loss of the tissue which holds up the bone. And eventually this can crumble and cause painful compression fractures. If you're a female, if you're older, if you've been exposed to a lot of steroids, or you have vitamin deficiency or GVHD, you're more likely to get this. Again, this is totally preventable with calcium vitamin D supplementation, exercise. There are medications which can be used to treat this, and for women, hormone replacement therapy if you are eligible. Avascular necrosis, as the graphic on the right shows, is a complete destruction of the joint, so that there's sort of tiny microfractures in the cortex of underlying the joint's cartilage, and this can cause severe pain. And this is related to steroids. and radiation, and usually will not show up on simple X-rays and requires an MRI. There are a number of specialist orthopedic interventions which need to be done, but often culminating in joint replacements. There are often general health issues which you should recognize, which are related to the transplant. Fatigue is very common. It's important to treat underlying medical causes, consider reducing your workload, as well as exercising and taking strategic naps. Sleep disturbance is common. Again, sleep hygiene is something everybody should try. Emotional changes will require a mental health counselor. Muscle cramping is also very common in the first few years. I recommend tonic water. This generally tends to improve over time. Brain fog, or so-called chemo brain, improves 1 to 5 years after transplant, but there are certain therapeutic approaches, including cognitive rehab therapies, as well as medications which can be used. For the eyes, there is a high risk of premature cataracts, as well as a dry eye syndrome. Having an ophthalmologist on speed dial is a very, very important consideration. Mouth, dry mouth, cavities, and the risk of oral malignancy require regular dental exams. Kidneys, liver issues can happen. Iron overload for certain patients, particularly men, will require bloodletting to remove the excess iron. And usually we don't do this for the first couple of years. Neuropathy is not uncommon and requires a foot exam as well as medications for pain and discomfort. So as you take control of your transplant, what are some of the questions you can ask your transplant team? One question is, ask about your underlying disease. When will you be deemed cured of your malignancy? Usually, if you have an acute leukemia and you haven't had a recurrence, I tell my patients that they can break open the champagne at 3 years after the transplant. Ask about graft versus host disease, particularly chronic graft versus host disease. Which organs are affected? When which organs are not affected? How long will you need to be on immunosuppressive therapy? What changes are permanent and what is expected to resolve? There are other non-GVHD complications. How are you affected? What complications are you likely to get in the future given the nature of your individual condition? Which potential complications are life-threatening? How long will you be at risk? How serious are these potential complications? And there's a lot going on. How do you prioritize addressing all these health issues? Also, in terms of reclaiming your life, how long will you be disabled? When can you plan to return to work or school? And then I think the biggest challenge many patients face is how to manage their care, because this is multidisciplinary, and often patients are now remote from their transplant center, and who is going to be responsible for your care? Who takes care of which components? Exactly when do you call the transplant team, or when do you go to your local doctor? When should you visit the emergency room? How quick should your reflexes be in getting care? Because you are much more vulnerable than a normal individual. And when do you call your primary care physician? So some of the things that you can focus on are, it's important to commit to survivorship. You cannot go through this process thinking, well, I'm feeling well, therefore nothing is wrong with me. No, because that's when problems happen. You need to learn about your risks, learn about potential complications and their timeframes, and aggressively seek to correct them. Not everybody will have access to a survivorship clinic, and this is a big gap in our field. You should generate very good habits such as sun avoidance, stopping all addictions including smoking, making sure you're regular with cancer screening, and having a good healthy diet. Activity is very important. I recommend weight-based training, particularly for women, because that really helps with your bone strength. You will have to develop a panel of consultants for your eyes, gynecology, skin, and dental. This is routine for everyone. I also recommend that you generate, take responsibility for your medical information, because you'll be going to various specialists, and the medical records don't automatically transfer, and nobody has the time to go over hundreds of pages of medical history. You could shortchange yourself. So it's important to carry a binder with the essence of your medical history, a survivorship care plan, and your most updated current medication list. So at Sarah Cannon, where we have a network of transplant centers, we have developed the concept of a dedicated survivorship clinic with the belief that simple screening and preventative measures can greatly improve health. So we are patient-centric. The patient is at the center of everything we do. And of course, there's a physician. There's also a nurse practitioner, nowadays called an advanced practice professional, so it could be nurse practitioner or a physician assistant. We have coordinators who are trained nurses who first, there's an acute allo coordinator who coordinates the patient in the first 3 to 6 months and then hands off the coordination of the patients to a long-term follow-up coordinator. And we have a model for standardized processing and staffing and training and resources, which is spread across all our centers. So at the heart of this approach is the coordinator, and interfaces with the transplant doctor, the referring oncologist, as well as the primary care doctors. And finally, on the right, you have all the other consultants, be it pharmacists, social work, as well as individual medical specialties. The transplant doctor, I feel, is the least important in promoting long-term survivorship health, because the transplant doctor will have very limited time and will have to focus on just the most important issues, such as malignancy restaging, active graft versus host disease, and infection. And a lot can slip through the cracks if you don't have everything else addressed. The way we do it is that patients have regular visits, as shown at the bottom, with the declining frequency with the medical team, be it the transplant physician or the nurse practitioner or physician assistant. Interspersed with these regular visits, we have dedicated landmarks or survivorship visits. At our center, we do our intake. The first survivorship visit is at day 100 to establish a baseline, and then we have another one at 6 months, and then annually for the first 3 years, and then at a declining frequency. At these survivorship visits, these are very long visits, these are about an hour, and follow a very exhaustive multidisciplinary evaluation, multiple tests done, which are all summarized at that visit. That visit is actually conducted by one of our nurse practitioners who can spare an hour for each patient at each landmark. And the focus is on all the other issues, putting aside the graft versus host disease, putting aside the active treatment of malignancy, etc., but focusing on general health issues. So this is how we have managed to thread the needle in terms of managing survivorship health. But we understand that such intense focus on survivorship is generally not available to most patients who have undergone a transplant, which is why when patients, for example, leave our center, we generate a survivorship care plan, which highlights some of the, the transplant conditioning, whether they had GVHD, what their risks are, what the recommendations are, and it's like a passport that the survivor carries with them to take them through life, especially as they move away from our center and they go home. In addition to the NBMT link, there's also resources available for survivorship through the National Marrow Donor Program. I encourage you to take a look at that as well. There's also some direct resources, not just information, which can help if you're enrolled there. So to summarize, It's important for our survivors to take charge. You have to commit to lifelong follow-up. Understand that being asymptomatic does not mean you're without health risk. Understand that you will require complex multidisciplinary care to promote your health. Survivorship clinics, if possible, are fantastic, but not everybody will have access to that. Individualized survivorship care plans are very helpful, and you should ask questions and seek help. It's important to own your health. This starts with general awareness, asking questions, staying organized in terms of keeping records, prioritizing problems, because you can't address everything at the same time, and generally committing to a healthy lifestyle. And finally, the reason why we do all this is so that we protect your health and you can enjoy your success. So thank you very much.
Now we will have Beth joining us.
Hi, thank you. First of all, I just want to thank Dr. Battiwalla. I could have listened to him all day. That information was fantastic to give us all hope for long and healthy. So I'll just jump right in. Hi, I'm Beth Ades. I'm so happy to be here with all of you and getting to share my story. I am a small town Iowa girl, married to my awesome husband, Justin, and we have one daughter, Haley, who is 15. I work full-time and I'm a cat mom. My diagnosis of MDS came in 2021, but getting to that point took about 7 months. I first went to my local doctor in May of 2021 with bruising on my legs, but other than that, I felt pretty good. She ran blood work that showed critically low platelets and then sent me to a larger hospital that was in Ames, Iowa for further testing. And my doctors there ran a bunch of tests, but we just weren't getting any answers. So then they referred me to Mayo Clinic in Rochester, Minnesota. I met with a couple different departments and teams before getting diagnosed with myeloid dysplastic syndrome, or MDS, and the only chance of survival was an allogeneic stem cell transplant. Both my sisters were tested, neither was a match, and then they located my donor. She was a 19-year-old from Germany, and she was a perfect 10 out of a 10 match. So I moved from Iowa to Minnesota for my transplant, then lived in Minnesota for 100 days post-transplant, and that was February 17th of 2022. Got to tell you, moving to Minnesota in the winter was not my best planning. But after transplant, I suffered from acute graft versus host disease in my liver and on my skin, and now I suffer from chronic GVHD in my eyes. Because of my GVHD, I needed to stay on my anti-rejection medicines for longer, so that delayed my vaccines. I only got them finished up pretty recently. So the time before transplant, when I was sick, staying from home until the time I was fully vaccinated, I was in isolation for 3 years. All right, Deadpool says it best. The worst part about cancer isn't what it does to you, but what it does to the people you love. And he also taught me how to say cancer in Spanish. It's el cáncer. I don't know if you're familiar with Deadpool or not, but it's played by Ryan Reynolds. His character is Wade Wilson, just an ordinary guy who has cancer. And then he goes through kind of a sketchy procedure that gives him superpowers. I'll just go ahead and say, make that jump. Maybe all of us have superpowers. Maybe we're superheroes now too. But what Deadpool's talking about is the guilt that surrounds us when we get sick. And I struggled hard with guilt, and I still do. I felt so much guilt for what I had put others through, like my husband, who had to basically do everything. You know, he was my caretaker, my driver, housework. For my daughter, who had to watch her mom go through something that was really, really scary. And for all the worry that I caused my loved ones. I mean, I knew I needed the help, but I had a hard time accepting it. So after day 100, when I returned home back to Iowa, I became almost obsessed with how to pay people back. I could not shake the feeling of guilt, and it was a really, really hard place to me. It was the passion and the drive was coming from the right spot, but I eventually learned how to pivot that guilty feeling of paying everyone back into paying it forward. So with that, I'm having lots of fun, and I'm getting creative. So far, I've hosted 2 blood drives and a bone marrow registry event on my first and second rebirthdays. That was awesome, seeing people fill up those time slots and come in and donate blood, and just how many people got on the registry. I've written a couple of blogs and recorded a podcast. I'm an ambassador for LifeServe. They're the blood donation centers in Iowa. Justin, Haley, and I did a virtual Stand Up to Cancer 5K together. You can see right there, Haley, she's out there for Ernest and Pee Wee Herman. So that was a lot of fun for us to do together. And then you can also see in the slides my husband's race car. So as a hobby, my husband drives race cars. And one of our cars this year we had wrapped as a tribute car for the NMDP and LifeServe. So besides racing the car, we've had it in parades and just other events. And it's been so fun because, little kids, big kids, everybody loves race cars. And they start asking lots of questions. And it's been a great icebreaker for me to start talking to people about, maybe getting on the registry or donating blood. Some of the things that I've learned the hard way that I need to be my biggest advocate, my own biggest advocate. So some of the things like mental health, my sleep, my sexual health, got to tell you, with my mom in the doctor's office room with me, that is not a comfortable thing to talk to my doctor about, but I did learn how to speak up. One thing that pops in my brain is about 6 months after transplant, I noticed this warm bump on my leg, and I'm starting to feel kind of cruddy too. So I met with my transplant team, but unfortunately that day I had a fill-in doctor, and he just kind of kept brushing it aside. And I finally ended up saying something like, I'm not going to head back to Iowa until I can get this checked out today. And he ordered the test, and sure enough, it turned out to be a blood clot. Also recently, at my latest appointment, my incredible doctor put my next appointment at 6 months, which was awesome news. We celebrated, it was great, but then I told him that it made me really nervous to go a full 6 months without having my blood drawn. So we talked about it, and we decided that every 2 months I'm going to have my blood drawn. He was happy, and I was happy, and we were both comfortable. So even though I have crazy respect for hematologists and oncologists, they're some of the smartest doctors out there, I know I'm the expert on my own body. So I encourage you to keep talking with your team about the tough stuff. If possible, if you have portal access, like an app, something like that, take advantage of it. Send those pictures, send those questions to your team. I also learned about the National Bone Marrow Transplant Link and their partners. My only regret is that I wish I could have learned about them sooner. There's this Peer Connect program, and I talked with 2 different long-term survivors through that program. And the first question that I asked both of them was like, how long was it before you could just put transplant behind you and get back to real life? And they both answered, you never really put it behind you. I was so hopeful that I could think of transplant as this dark cloud on my timeline, but something like that I went through, but got back to real life. But I'm so glad that's not true. For a while, transplant defined me, and now I've allowed it to change me and be a part of my everyday world. I've learned so much. I've met some of the coolest people I've ever known. I live my life in the present, and I don't take things for granted. We've survived something most people have never heard of, and we've lived to tell about it. My faith has deepened. God had transplant in his plans for me. I know that now I have suffered well so that I could live through this season and help others. All right, fun, right? Humor, hair. Let's talk about it. We're going to lose it, right? We all know we're going to lose our hair. So let's have as much fun as we can with it. So in the one picture you can see Haley. I donated my hair before I moved to Minnesota. So here she's cutting off all my little pigtails. The next picture is my one and only wig that my coworkers sent to me, but the joke was on them because I wore it during an entire Zoom meeting. And then my dad and I having similar hairlines. Let's see. Oops. Okay. Oh, sorry. Here we go. I thought I got ahead of my slides. Here is me. My favorite Halloween costume ever, Elle from Stranger Things. My mom in the waiting room, haven't we all wanted to do that? How many hours of our lives have we spent in waiting rooms? And, oh, there's Haley pretending to be run over by the race car. So just a little bit more fun things that, we try to do. I owe it to myself to keep up with new information about transplant. So every month I've made a promise to myself, and I've held on to this. I attend at least one class, a lunch and learn. I read articles. I listen to podcasts. Some days, even just listening to others talk helps me feel connected. Turn some days into today. When I finally got the green light to be out in public again, I started taking full advantage of it. I took my first vacation for many, many years. This year, I attended a concert. I went on a hot air balloon ride, my first ever girls trip, and I recently attended the NMDP Gala. I try hard not to take one day for granted. Taking care of myself is actually easier said than done. My recipe for self-care is rest, therapy, nutrition, and movement in that order. I didn't want to admit that trauma had taken its toll on me. I just had gone through something so incredible and difficult, but I felt like admitting that to myself that I needed therapy meant that I was letting myself down, and really everyone who was, rallying behind me, I felt like I was letting them down. At least at this current point, I don't want to imagine my life without therapy. I think therapy is for everyone as long as you're willing to put the effort in for it. Embrace your pace. Don't compare your journey to anyone else's. It's your journey. I was able to start running again, which is great. It's not as fast or as far, but, I'm doing it. And one other thing that I want to talk about, I check in with myself first before going for a run. If my body's saying no way, I know how important movement is, but listening to my body is more important. And so rest days are necessary. All right. Some of the things that I've done recently, I grieved for my old transplant life. I really longed for those things that I could no longer do, but now I'm focusing on the things that I can do. So I dove right back into hobbies like baking and crafting, and I've really enjoyed getting creative, making things with my hands. I also joined a creative writing class earlier this year through one of the Link's partners where I learned how to express myself, and I would encourage everyone to start writing and journaling. It's really one of the best things that I've done for myself. I have to go ahead and talk about my donor quick. I learned her identity earlier this year, and she's incredible. She's in medical school. We email often, and we've shared photos, and someday we hope to meet. And where I am today, I've returned to a job that I adore, and I am genuine and real in every relationship, and I say what's in my heart and tell people as often as possible how much I appreciate them. I finally feel like I'm right where I'm supposed to be. I choose joy every day, and I've allowed transplant to change me for the better. I'm so grateful that I got to hang out with all of you today, and a huge thank you to the National Bone Marrow Transplant Link.
Thank you so much, Beth. I really appreciate your wonderful presentation, and I'm sure some of the things you had shared are things that ring true with others. I want to thank everyone that came here today. First and foremost, I want to thank our sponsors, the Leukemia and Lymphoma Society and Johnson & Johnson. I also want to thank our speakers. I know Dr. Battiwalla was answering questions during some of the presentations, and if anyone has additional questions, you can certainly reach out to us and we'll do the best we can to help. But if not, I also encourage you to take some of the questions that you might have gotten here today to your own provider. I want to make sure everyone is aware that we will be having our cGVHD webinar coming up, so keep an eye out for that. You will see on our website, as well as you will be seeing it in our newsletter, or you can go to our website directly, and we'll be happy to assist in getting you registered. But anyway, you also will be getting a survey for today. This helps us with future programming, and so we will be sending that out, and we just hope everyone has a wonderful day. Thank you for joining us, and we wish you much health in your survivorship.
Thank you. That does conclude today's webcast. You may disconnect your line at this time and have a wonderful day. We thank you for your participation today.